Hi, Miranda. We're going to give it just a couple more minutes to see if some of our other members join us. We actually have a new member.
Arthur is logging in as we speak.
Excellent. And Erin, did you hear from Melanie? Did she ever respond to you?
I did. She is actually also joining our IDD TAC. So we had been in communication prior. So I sent her the minutes and the agenda for today.
Okay.
And the calendar invite as well.
I hope she'll be able to join us as well. I know that we have still one opening for our Kentucky Association of Community Health Worker representative, and our Frisky representative has been off due to a death in her family. So I'm not expecting her to join us today.
I do hate to hear that. I'll be thinking of her.
Yeah.
And it does look like you do have a quorum. If I see Melanie pop in, unless I missed her when she was logging in, I'll let you know.
That would be great. Thank you.
We can go ahead and turn it over to you if you like, because it looks like the waiting room is clear.
Hey, good afternoon, everyone.
Hello.
Hi, Arthur.
Hey, Arthur just sent a message to the group chat. He wants somebody to read it.
Arthur is saying if the meeting runs past 3 o'clock, he'll have to leave. And apologies for leaving early for another meeting. So thank you, Arthur, for letting us know. We'll try to get to the items that that you are usually interested in covering.
You have one. You have one new.
Are you saying new business?
Yeah. You have something to add under new business? Okay.
Do you want it right now?
Why don't we, we'll do our introductions and we'll approve the minutes from our last meeting, and then we can actually jump to new business and cover that item, Arthur. Yeah, Deputy Commissioner Veronica Judy Cecil is also not quite, I don't think she's on yet. So that'll give her a little time for some of the old business items that we're going to cover. So why don't we go ahead and do introductions? I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health, and I'm chairing the Consumer TAC. And Brenda, Arthur, and Miranda, if you could just introduce yourselves.
Hi, I'm Brenda Menino, and I'm the representative for AARP.
Is Arthur Campbell
with
P and A?
Yeah.
Miranda Brown with Kentucky Equal Justice Center.
All right, well, it's good to see you all. I was hoping that we would have our new member joining us today, Melanie Tyner Wilson. Of course, she may also join us a little later. She will be representing the ARC in place of Patty Dempsey. So of course, want to wish Patty a farewell. I'm not sure if Patty is on either. I don't think I've seen her here today. But hopefully she will continue to join us for meetings as she's available. So wanted to share that news with you. We do have a quorum, as Erin stated, and we'll move to the next item, approval of minutes from our previous meeting. That would be our April meeting. has everyone had a chance? And of course, it is a long transcript. I understand that. But can I get a motion to approve? Okay, thank you, Arthur. And a second?
I second it.
Okay. That was kind of a tie, so I'm going to say Brenda. Thank you both. All in favor say aye.
Aye.
Any opposed? Okay, motion carries. So that is approved. Thank you all. And now we'll jump down to new business and add an item for that Arthur would like to raise for the meeting, and then we can go back up to old business. So Arthur, tell us what you'd like to discuss in the meeting today.
He said, wait a minute. Yeah. You said what? Wait for 1 minute. He's trying to get his page. He sent a message on the chat. He said you guys can read that.
I see that. A proposal to overhaul the Michelle P. waiver and other waiver programs in the Commonwealth. And Arthur is asking us to bring a fellow colleague who serves on Kentucky's Protection Advocacy Advisory Board to the August 15th TAC meeting. This person has done a lot of time assuming research on Kentucky's waiver system, especially the Michelle P. waiver, and he has a few ideas that will make the waiver stronger for participants, and his suggestions will make more sense from a dollar and cents perspective too. So Arthur's asking the chat to bring one of a colleague and two other people with disabilities to the August 15th meeting. And after the TAC listens to this person's suggestions and ideas, Arthur would like to make TAC recommendations to the MAC. And Arthur, I am absolutely fine with having guests attend our August 15th meeting. We can add them to the agenda. I don't know if Brenda or Miranda have any other thoughts there. I got a thumbs up from Miranda.
It's fine with me.
I'm just making notes here. So that will be for the August agenda. Arthur, is there anything else that you want to say about that now, or you just wanted to make sure that we had it? Okay. All right. We will do that. Thank you. I think that's an important discussion for us to have. So absolutely. So let's jump back up to the top of our agenda. Well, agenda item 4, old business. And these are, of course, topics that we've discussed in previous meetings, and we'd like to have a status update on the following. The first is our standing data request for how many Kentuckians are currently covered under traditional, expanded, and emergency limited and presumptive eligibility Medicaid.
Emily, if you could give us just a second. Veronica is logging in as we speak.
Yes, absolutely. We'll just take a little pause.
Hi, everyone.
Hello.
Hi, Veronica.
Sorry for being late. I had a meeting run over.
Not a problem. We were just starting to go through our old business, and we're asking for an update on the number of Kentuckians currently covered under the traditional expanded emergency and presumptive eligibility Medicaid.
Oh, okay, I'm gonna have to phone a friend.
I was gonna say, it's not always the numbers that you provide. There may be somebody else there who has those.
Yeah, let me see. I don't know. Is anybody else from Team Medicaid on that can help with that? If you don't mind, let's pause on that one.
Okay.
And I'll see who can help me.
All right. Yes, we can come back to that. And then a similar question, how many people are currently covered under the 1915C waivers or on the waiting list? And if we need to come back to that one, we can.
Let's see if anyone from LTSS is on to help with that.
Hi, this is Dr. Terrio. I was on the IDD TAC yesterday and I can tell you what those numbers were that Alicia shared with us.
Thank you, Dr. Terrio.
It looks like there are 8,284 people on the Michelle P. wait list, and 70% of those are children. And then on the SCL wait list, there's 3,172 people.
This is Leslie. I'm so sorry I got disconnected and I had to come back. I'm sorry. I've got the information too if you need it. I apologize.
Oh, that's fine, Leslie. And yeah, if you do have.
I've got it. Pam is
numbers.
not able to be on. The schedules were a little tough today. So I've got 32,843 individuals are currently enrolled in the 1915C HCBS waivers. The wait list for long-term care ABI is 16. Michelle P is 8294, which Dr. Terrio just gave you. And then SCL is 3172.
3172. Thank you. And I understand that today was not our usual day, so I appreciate you all accommodating our reschedule. As far as traditional expanded emergency and PE Medicaid, do you have those numbers too, Leslie?
I just dropped them in the chat, Emily.
Oh, perfect. Okay.
Bless you, Erin. Thank you.
All right, so we've got a few numbers there. Appreciate that. Does anyone have any questions about the numbers that have been shared so far? And then if you do have any others, if you want to follow up by email or put them in the chat later in the meeting, that'll be fine. On a related note, our next item is the PHE unwinding and Medicaid renewals, everyone's favorite topic to
I do have that.
I figured you would, Veronica. I feel like it's all you need to do these days.
Yeah, let me.
And I realized that I didn't really update my questions under this section, but I have a feeling that you have an update for us anyway. So,
okay, let me share. So, we have been doing, and by the way, we're finalizing. I know we usually try to post every week an update, and we're finalizing that. We wanted to. This is important information, and so we want to make sure it's as accurate as we can get it. Couple of caveats to Medicaid data, and apologize for not introducing myself, Veronica Judy Cecil with Kentucky Medicaid. It's fluid because it depends on where we pull it, what day we pull it. For example, if we pull this information and there are several cases that are with the worker and still determining eligibility. Today, that number might not be reflected in a total of approved or terminated, but tomorrow would be. So it just, have to remember that the information is only as good as the day we pull it, at the time we pull it, because even throughout the day that happens. But so what we've been doing over the past week is just making sure that information is, as accurate as possible, that we're putting the numbers in the right bucket, and then to be able just to share it in a way that's understandable can also be a bit complicated. But so here is a snapshot of the May renewals. The number that we might have started with at the beginning of April for a May renewal is not going to always be the same number when we get to May 31st. And that reason is because people will drop out of households or be added to households. Let's say somebody, there's a child born. So that number gets fluid too. But on May 31st, when we did the snapshot on June 1st, the number of individuals that were part of the May 31st renewal was 74,004 individuals. The other thing I would just want to remind everybody that kind of complicates this is that we've been reporting a lot at the case level, because it is the case level, the household level, that we process our eligibility determinations. It's the case level that we're utilizing to monitor our workforce and the tasks that our eligibility workers are processing. So it just, gets a little difficult, because we will be moving from a case level to an individual level now as we proceed through the unwinding period. We will just make sure that stakeholders understand which metric are we using. So for this information, this is at the individual level. So our individual member, not at the case level. So again, that is 74,000 individuals. Of those 74,000, we were able to approve 37,182. The majority of those, although I didn't break it down and I apologize for that, but the majority of those were the ones that we were able to, at the beginning of April, go out and automatically renew. So the lion's share of that is really those ex parte passive renewals, where we went out, we pinged the federal hub, and we were able to determine and verify all information that we needed to be able to make the determination. So about 34,000 of those are those ex parte. So the remaining of those approvals are ones where somebody submitted something in response to a notice or a renewal packet if they were active renewal, or a request for information if they were a passive renewal. So a very small number, you can see if you subtract around 34,000 from the 37,000, a very small number of individuals who were approved because they responded. So let's get to the really kind of difficult number here, and that is, 34,124 individuals were terminated from Medicaid as part of the unwinding. The number that you may see reported on our under our Medicaid statistics website, that monthly report we post, is going to be a little higher in terms of the number that have been disenrolled, because we have a normal churn on top of that. But for unwinding, for the May renewals, it is a little over 34,000. Of those, almost 6,000 of them, though, were eligible for a QHP and advanced premium. So QHP is that qualified health plan, that commercial-like plan that's on the state-based marketplace, the Connect, and also eligible for the advanced premium tax credit. So almost 6,000 of those that were terminated were identified as being eligible for a QHP and APTC. Of that, and this is just data as of June 1st, we tracked 460 of those had enrolled in a QHP. So those are individuals that should not see any gap in coverage because they're being able to move directly from Medicaid to that qualified health plan coverage. I think the concern here is that there's a lot that we could not identify having enrolled. And so they are likely going to have a gap. But we are working to outreach to those individuals and try to connect them to that coverage on the exchange. And that's what we'll continue to do during this time. I think the bigger concern here and what we honestly are continuing to dig into is the 24,000 individuals who didn't respond at all. So they received a request for information or a renewal packet and did not respond to us in any way. So those individuals, again, we've tried to outreach to these folks. The state has a minimum of 3 times. The managed care organizations have attempted to reach their folks. And for whatever reason, either they know they're ineligible or they just didn't take the action, or maybe we actually didn't reach them. We left messages or we haven't been able to locate them. Then, they have been terminated and they will be put in the bucket as for procedural reasons because they did not respond. So just a reminder that we will continue over the next 90 days to try to reach these individuals and make sure they understand if they are eligible for Medicaid, or even if they're not sure, but submit that information or verify that information so that we can process their determination. And if they are eligible, then we can reinstate them back to that May 31st date so that there's no ultimate gap in coverage. Or if they're not eligible, then continue to make sure that they've signed up for their employer plan, or they've signed up for a qualified health plan or Medicare, depending on what the situation is. So it's a large number. I'll pause for a moment on the May renewals, see if there are questions.
Thank you, Veronica. Any questions? It sounds like Brenda has one.
I have a question. Of that number with the 24,521 who had no response, you've had no response from. So that's subtracted from the 34,000 terminations?
Yes. So so what's missing in this bucket? So yes, so you take the 34,000 is the total termination. Of those, we determined almost 6,000 of those were not ineligible for Medicaid and but eligible for QHP. And then the other subpopulation to that is the 24,000 that didn't respond. What's missing here, I didn't have, again, I know I'm missing a couple of metrics, but the other bucket under the termination, the subpopulation of those we determined ineligible and not QHP eligible. So that the rest of that is folks that were terminated because we actually determined them ineligible.
So the no response, you had attempted how many times to?
The state attempted no less than 3 times. By
Mail, phone?
Primarily calling. So all the households were called. Some were text if we had a phone number that was able to receive text. So we had a mobile number, or email if we had an email on file. So we tried all modes of communication to reach individuals.
Now, that's a large number that you've had no response.
Veronica, I know that some of these individuals aren't eligible any longer, but it obviously seems like a larger number than the ineligible folks. Can you remind us what the returned mail rate was? I know it's much lower than it has been historically, but how many of these 24,000 people didn't receive?
For May renewals, only 1,700 returned mail. So it was a really, really low number.
Yeah.
And for every single one of those that were returned, we reached out to the household and, where we could verify, we then resent their renewal.
we appreciate all of the affirmative outreach that you all are doing. I know that is not typical. This is above and beyond what you typically do.
Yeah.
Any other questions related to the May report? I'm assuming, we're 1 week into July. So I'm
Yes.
assuming a few of these people probably have
Oh.
gone to the doctor now or to the pharmacy and have tried to
Yeah.
either, get a
Yep.
service or a prescription. Have you heard
Yeah.
from anyone who's like, oops? I missed
Yeah.
it?
Well, so surprisingly, we have not heard a lot. We had on June 1st, we had a couple of folks that got escalated up to get that had it presented for a prescription. We were able to help them, but otherwise, we're not seeing it. And so it's quite strange. So one of the things that we are doing and the managed care organizations are doing for their members is going back and looking to see, is there a claim within the last 30 to 60 days, and reaching out to those providers to see if they've been in touch with the individual. We did send on May 31st, we did send a communication to all the pharmacies to make sure they remembered that June 1st, people may present without coverage and what to do if that happens. But we're really kind of surprised we're not hearing more from folks trying to access services.
Yeah, I could imagine that if somebody had enrolled in employer-sponsored insurance or something else and weren't really using their Medicaid coverage,
Yeah.
they wouldn't have any active,
Mhm.
claims, and that would be more of a kind of answer to that. But if people are actively using their coverage, you would think that they would still need it.
That's correct. Yeah.
Yeah. All right. Well, thank you for that update. Did you have some June numbers to share with us? Yeah.
Oh, sorry. Yep. Oh, that's what that was. Okay. Just a high level right now. So for June, we did have, this is at the case level. We did have almost 80,000 cases. And of that, we had a larger number of passive versus active. So remember, passive are the individual cases that we can identify as being able to go out there and successfully complete an ex parte. So we had a little over 57,000 passive cases. Of those passive cases, once we ran ex parte and we went out and tried to ping the federal hub, we dropped almost 28,000 of those to a request for information, similar to what we did in May. Want to give those folks an opportunity to reach out to us and verify information in case what we're getting back wasn't accurate, before we took the step to terminate. So we do have that many requests for information out for June, and then we have 22,337 active cases for June. So those are the ones that are receiving the renewal packet. And then we're in July renewals. So at the beginning of June, we identified the cases that will be subject to a July 31st renewal. Of that, we have 48,490 cases. This sounds like a small number, and it is in terms of the cases that are distributed across the 12 months. The reason for that is because we have moved cases with children to later on in the unwinding period because we're implementing the continuous coverage for children. And we want to be able to extend that coverage if a child's determined eligible automatically to the child in the system. So those system changes won't happen until September. They'll go live in September. So we pushed a lot of the cases with children to later in the unwinding period. So of those 48,000 cases, our system has identified a large number of those to be passive, 39,326, and then 9,254 are active. We have not, by the way, we have not run ex parte. That's the system is going through the process now, so that won't be completed until the 10th of the month. So So we can't yet report how many of those might drop to a request for information or how successful ex parte is at that point.
Okay, that makes sense. Any questions about June or July?
Like I said, we should, we're finalizing the graphic that we put up, the report. So hopefully we'll have that up today.
Okay, and I know, Veronica, that on the notices, people get, information about if you think that this is, if you need to a reconsideration or if you want to appeal, I can't remember the exact language, but it's there.
Mhm.
Of course, people may not read that low and then that far down in a notice,
Yeah.
or, may just assume that they're ineligible and there's nothing to be
Yeah.
done about it. Is there anything that you're planning on putting out more as a PSA or a graphic style about, how to get your coverage back
Mhm.
if you didn't complete, your renewal?
Yeah, so we have a couple of things planned for that. One is to continue to on social media and in other ways, make sure folks do understand that they can still submit information within the 90-day period. I already mentioned we're leveraging providers. So we'll continue our outreach to providers and education to provider groups so that they understand when somebody walks in and they've just been disenrolled, it's really great if they could encourage that member to reach out to connect on the hotline or to DCBS and check on their ability to get reinstated. And then the managed care organizations will continue outreach. I mean, the plan is to, even though we've got June and now July renewals starting, that we'll continue to reach out to the May renewals every 30 to 60 and before that 90-day period ends, so that if we can contact somebody who falls in that period of time and is potentially still eligible, we can get them back on. So there really is a multi-pronged effort to keep that in keep everybody's attention on that and focus on that.
That would be great. And if you could also report any number of like the reconsiderations that do, result in
Yes.
someone getting their coverage back, if we could get that number in the future, that would be fantastic.
Absolutely. We are tracking that. So we, once June 1st hit, we started, the system will start tracking reinstatements. So we're happy to share that if hopefully we'll have some to share.
That sounds good. Any other questions related to that?
I have a question. Maybe I missed it, but did you come back and give us a number on how many Kentuckians are currently covered under traditional Medicaid?
I know that Aaron, not yet. I'll actually, once I start speaking, I'll go pull those numbers. I know Aaron posted total and PE, but we'll break it down to traditional and expand it. I just have to pull the report up.
Okay, thank you.
All right. Well, again, thanks for all the extra outreach you all are doing, and also to the MCOs who are on the line right now. We appreciate the extra effort. So,
and let me say thank you all. I mean, the advocacy organizations have been a huge help in getting the word out, and all our connectors. It's definitely all the stakeholders across Kentucky, I think, are part of the effort, and we appreciate it.
yeah, we're certainly trying. And I have to say, it feels like a mystery to us right now, too. So I hope that at some point we better understand who this population, the 24,000, is, and what kind of more targeted strategies we can come up with to reach them. And if we can figure out, who those individuals are who are likely still eligible. I mean, I think that's what we're all trying to figure out right now, and how best to reach them. But I think that looking at claims data and reaching out to the providers is great. I'm glad you all are doing that. So the next item that we have here on the agenda is the Home and Community-Based Services Rate Study. And of course, the 10% increase that was approved by the legislature, as well as the adjustments that were being made for PDS employees.
So Emily, I can talk a little bit about that again. As you said, the document might not be updated, so I'm not sure where you were with Pam last time, but just a little bit of information. The rate study is currently with executive leadership, and I think the first round, 10% rate increases in the system and eligible to be billed. As far as the PDS employees, I think the participants have to contact their support broker or the case manager, and rate increases should be, of course, person-centered and requested by the participant or the PDS rep and not the employee. So that's about what I have today, but I can get you additional information if you need it. I wasn't sure where Pam had left off with you last time as far as updates.
Well, I think everything that you shared today was an update.
Oh,
so-
okay.
Yeah.
Yay.
As far as the 10% rate increase, you said it's in the system and eligible to be billed. So
To
is
be
that
billed, yeah.
automatic, or does somebody have to?
I think I can double check with Pam and I can get you information via email if that's okay, but I think it's currently in the system and eligible to be billed by folks now. So I'll ask her for sure if that's okay.
Yeah, I think what I'm trying to clarify is just if when you say eligible to be billed, is that something that has to be done separately than regular billing? Is it optional?
Let me find out because I have not seen the change order. Okay.
Okay, thanks.
To be billed, is that automatic or something special? Okay. And then I think I've got the next one too. So a little bit of good news do you want me to go on to the next one? I'm sorry.
Let me just ask if anybody has any questions related to what you shared. Okay, it looks like we can go on.
Okay, so for the PACE program, got some good news. Kind of excited about this. As you're aware, we've got 2 providers currently, Bluegrass Care Navigators and Horizon PACE. So very happy we've got those folks, and we now have a 3rd provider that's enrolled and who will be taking clients in Jefferson County beginning next month. I think their grand opening is middle of June. June the 16th, and they'll start doing enrollment 7/1. So we're very happy about that. We've currently got 106 individuals enrolled in the PACE program. And just to let you know, we've got multiple other organizations that are enrolled in that are in the middle of the enrollment process and have submitted their applications. So it's all very exciting. This is definitely something that's growing, and we're happy about that.
Great. For the 106 who are enrolled, can you and this may be for a future meeting, but
Okay.
I'd love to know what kinds of services that they're getting, how it's different from a waiver program, and just generally what their experience is with it.
Sure.
If it's meeting their needs.
I'll talk to Pam about that too and see if we can get something back to you. Or do you want to just put it on the agenda next time? That would be fine too.
Yeah, we can do that.
And I think somebody put in the chat, Emily.
A mass adjustment for the
Yeah.
rate increase. Okay. that's
Thank
great.
you. So I didn't have that information. Thank
That
you.
makes sense. Okay. Let me just make a note that I'm going to add this to the next agenda, or I will forget.
And again, I apologize that we were so pulled today.
Can I ask a question? What did you say were the care providers? You had Bluegrass Care Navigators, and what
And
was the other?
Horizon PACE.
Mhm.
And then our new one is, hang on just a second. Let me get the name. Sorry, Senior Community Care, and they will be in Jefferson County or out of Jefferson County.
Okay, thank you.
Really excited about the program and how it's taking off.
Okay, and just looking at the chat again, the PDS employees get an increase going forward, not retroactively, or retrospectively. So I'm assuming that participants really need to know that they can make these increases and do it as soon as possible to get the maximum benefit from it. Are all participants aware that they can make these rate increases.
Yeah, and Emily, I'm gonna let Pam speak to that if that's okay, to talk to you about it, but I don't believe we can retroactive that on the PDS piece.
Yeah, okay.
Trying to look in my notes, but I don't believe that's retroactive.
Yeah, no, I mean, that it sounded pretty clear from the message in the chat too. I was just wondering if all participants are aware that they can make those increases, and if,
I'll double check, but as far as I know, Pam's usually really good about getting information out, but I'll double check on that for you.
okay.
Leslie, I believe yesterday in the IDD TAC, sorry, this is Erin. She said
Yeah,
that
I
there
missed
was
that one, sorry.
a mass letter that was sent out
Okay.
regarding the
Thank you.
PDS, so people should be aware.
We had discussed it, but I have not seen the letter, so I apologize.
I will make a note. I believe she's supposed, Alicia was going to email it to me to send to the IDD
Okay.
TAC, so I will make a note to also send it to the consumer TAC.
Wonderful. Thank you.
That sounds good. Thank you. Our next item here is the DMS report on the hospital rate improvement program, quality metrics and data. I put it on this agenda because I think we discussed it being available now.
It's not, unfortunately, it is not. I mean, but I do want to share at a high level what is being looked at as far as the quality metrics per se. This doesn't give all the actual metrics, but what the targets are. And so I'm going to put that information in the chat. Hopefully we will have something more definitive for you in the near future, but like I said, this is at a high level what they're looking at. It's for state fiscal year 2023. So we have readmissions within 30 days, sepsis, CODI, C. diff, social terms of health, concurrent e-prescribing, hours of physical restraint, seclusion, screening for violence risk, discharge to home and community, discharge with an opioid prescription, opioid uncomplicated vaginal delivery, maternal depression and SUD, suicide screening in the emergency department, emergency department opioid use for ankle sprains. So that is it at a very high level.
Okay. So you said you'll put those in the chat?
Yes, I did.
Okay.
Did I not hit enter? I guess not.
I
There
don't
we
think,
go.
yeah, there you go.
There we go.
And since we have so much being added to the chat today, Erin, would it be possible for you to send us the chat transcript?
Yes, ma'am. I
Okay.
usually pull all the pertinent information from the chat to email to you guys after the meeting anyways. And then I try to alleviate all the cluttery chat.
Yeah, that would be perfect. Thank you. So those have been shared. The quality metrics or the targets have been shared. Do you have an idea of when you'll have data on performance?
It's being audited. I have asked Melanie Landrum with KHA the status of that, so we might have it by the next time. I
Okay.
can't make any promises.
All right. Well, we'll put it on the agenda again and we'll see where things are at. Thanks.
Okay, and for the court reporter, this is Angie Parker with Medicaid. I didn't introduce myself, sorry.
Our next item here is the certified community health worker reimbursement, which I know is going into effect on July 1st. So we wanted to know what the status was of new regulation and any guidance to be shared with CHW's providers and community-based organizations.
I don't know what, if Jonathan's got on the phone, but I do know that the legislation has been submitted.
Angie, I'm here.
Okay, great.
Hello, everyone. Our regs are going through the process. They are currently out of our hands. They're being looked at. They're going through the layers of approval that they will need to get before they're filed. I think we would expect them to definitely be filed, but before July the 1st. That's when our federal approval date is. There's still some other discussions going on, but we're pretty happy with the status of the SPA and the approval, how that approval looks, and then House Bill 525, so that's going to be the general contours of the CHW program right there. And so that's so it's ready. It's going through the process, and it will be it'll depend on the DPH reg. You know, you'll have to be certified by the DPH, but pursuant to the DPH reg, whether that is having historical service that you're able to get the certification, or whether you meet the education requirements. And then you'll have to work for one of the sponsoring providers that's listed in KRS 205.648. And then the services will have to be ordered by what we're calling an ordering provider in the reg. And that's going to be physician, dentist, PA, APRN, certified nurse midwife. And I think that's it. So the people that are working under the umbrella of the sponsoring provider. And then it's going to include all the services in House Bill 525, which is codified in KRS 205.648. And I really hope I'm not telling you the wrong statute. I think that's right. I'm shooting from the hip. But that will also be in the reg. Just kind of, there's some additional wrinkles and examples that are in the state plan that I thought was important enough that we also make sure that it's included in the reg as it goes through.
Thanks. The sponsoring provider list, was that in the KRS that you just mentioned, the 205.1648? Okay. And then ordering providers, when you say ordering providers, I mean, obviously they are ordering CHW services for their patient. Will they have to have seen that patient physically or even via telehealth first before, or is it more of a standing order that based on some criteria, they could order services without having seen them themselves?
We will want to check the final version, but as I have drafted it, it is ambiguous.
Okay. Okay.
This is Justin Derringer.
And he may correct me.
No, you're right. I was just going to say, I think we had sent you a FAQ over to review maybe, and that was one of the questions in the FAQ that we had sent over. That is correct. They do not have to actually physically see the individual first. It can be as long as they prescribe those services for the patient, then that's all it needs to be done.
Okay. Justin, I know that we had discussed looking at that FAQ. I don't remember getting it from you, but it could have come from someone else. So maybe I missed it. Could you just resend it?
I will do that.
Thank you. I could have missed that. But yes, I will definitely take a look at that. And I think that cleared up my question about ordering providers. So thank you. Does anybody else have a question about that regulation, or maybe it's more than one?
Jonathan, in the chat, I think Miranda was asking to clarify the KRS to make sure she wrote it down properly.
It's 205.648.
Oh, 648. Okay, great. And this guidance, I think, is what Justin is talking about with the FAQs. So that's something that you all are planning on putting out soon, it sounds like.
That's correct. I think the last piece, I think we were going to give you all a chance to review that for a day or two, and then we were going to go ahead and send that out.
All right, that sounds good. Anything else related to that? We can move on to the next item, the value-added benefits side by side with behavioral health items, which Aaron, thank you. I did get that when you sent it yesterday or the day before. So thanks for sharing that with us. As I was looking over it, it's a lot of information and it's a good list of services. I'm still personally, and how I'm sort of reviewing it, I'm still confused about which services are really the value added services and not just covered services.
And Emily, we had challenges with that ourselves in putting this together. I do know that one of my staff, Rachel Rarig, who helped to try to make it a little easier to read. As far as putting categories, of things, I can say that some of the value added benefits are actually covered benefits such as care management programs. That's part of their contract, that, they provide those services. So it is, I can understand your confusion on that, but instead of, I wanted to get it out there. So we would have somewhat of a final document to show that these are behavioral health services, whether or not they're value added or not. They are, but to your point, there are some of these things that are
Yeah.
actually just benefits.
I guess if I were looking for that, I think I would want, seeing as we have 6 MCOs, maybe a list at the top of covered services that all MCOs should be providing. And then, keep the separate columns only to the value added services, just to make it really clear, because I can imagine that some MCOs haven't included all of their covered services here in this list. I just don't want someone to look at it and think that something isn't a covered service if it is.
Well, it's all covered service. These are all covered services, whether they're value add or benefit. I mean, they are all
Well,
covered.
but for
services per
consistency's
MCO.
sake, if one is putting case management and another MCO isn't, that could mean that somebody assumes that MCO doesn't provide case management when they actually do or should. It's also just such a long list and hard to really do a comparison. So if we could put, covered services at the top, all MCOs need to be providing this, and then have only the ones that are value added. I think that would help to kind of.
Well, behavioral health had asked for both, so that's why they're on here this way. And I understand what you're saying, and
I think
was
both could be on the document and just be separated. But if this is what the behavioral health TAC wants and approves, then that'll be fine.
Emily's camp in that. I think that it couldn't be confusing, but if you just look at this and want to make sure that all your behavioral health needs are covered, and if you would just scroll to the bottom and see, well, which one has the longest entry, and think that would be the best one, when actually some of the others might cover the things you need, and they just not listing it because it's not right. It's a good benefit. It's not fully transparent to list them.
just as an aside, all the MCOs were given this. They were asked the same thing. If it's not on there, they can come back to us and let us know. I would like to really put this to bed. I mean, if you're really wanting it, because I started to do that and go back to the MCOs and say, this is case management. You offer this, whether it's not a value add. But if we need to go back again, we can do that.
Well, or the value added services could be, in a different color. I think we just have to differentiate between what should be a covered service and what's value added. To me, if we're calling it a value added list, and value added is all over this, I think, and people can't, consumers aren't going to be able to differentiate between value added benefits and services from covered services.
Well, the top says value added services, including behavioral health, value add benefits and services. So I don't know, potato, I get it. If we need to go back and make it a little bit more clear, it'll be a little bit longer.
Well, I think it
Okay.
could actually be shorter. I think if you consolidate all covered services at the top, you take them out of the table, and it probably would actually make the whole thing quite a bit shorter and easier to read. But I understand that you've gone through a number of iterations of this.
And I do want to make sure that
input.
everybody understands that the end, things that aren't necessarily behavioral health, that, for example, maternal health programs that they have, that is, that's offered to whether, regardless if you're, behavioral health person or not. So this is an all-inclusive behavioral health and value add in general outline. But I'll take another look at it. Don't.
Yeah, so in the table and, again, if the behavioral health tech wants it this way, I want to ask for changes. But if they would be open to having covered services at the top and only using the table for value added, I think that could clear up some of the confusion.
I mean, yeah, I get what you're saying. They were asking for more than just value add.
Right.
But I'll take another look at it.
Thank you. And then we had also talked about, having some sort of supplementary guide so that people had additional details about these value-added services in terms of who's eligible and how to access a particular benefit. So is that something that you all are working on?
That's typically included in each MCO handbook, and I know we've talked about that before, but that not working on, to answer your question, not working on that currently.
And are you planning on it, or should we just make that a recommendation?
We can look at it a little bit further, how best to do that.
Okay. Yeah, I think for
Sorry, this is Stuart on of WellCare. I was going to say, just a couple days ago, just as a suggestion, I took the grid, and at the very top for like the welfare column, obviously I put our phone number and website, check here for a value added benefit. And then in parentheses next to each value added benefit that had any kind of thing that you had to do, I would just put that, I put that in parentheses, like, must get a preventive visit next to each one, the ones that did have that. So that was just a thought.
It will be coming back out to the MCOs again to make sure that any particular things will be changed as requested.
Yeah, I think that's good information. I mean, people need to know what those additional details or requirements are. And because I understand the side-by-side is meant to be an abbreviated, sort of summary, having that supplementary guide would, be where you could include all the other details. So that's sort of how I would envision it. And, for some people, they may go to every MCO handbook and take a look for those. But if you're a connector or someone who's assisting, a member, it would be easier if you had something that was pulling it all together.
Okay.
Miranda, anything else related to that? Okay. The next item we have here is network adequacy. Of course, we've discussed this quite a bit, but I think since our last meeting, the request that we made to MCOs to report out of network providers, some of that was shared verbally during the meeting. Some MCOs said that they were going to follow up, and I got some follow up, but I don't think that we've heard from all 6 MCOs with these specific, numbers. Then how many out of network providers were approved in 2022, and what were those provider types? So just wanting to kind of re-up that ask. And if we could get it in writing, even if you did share it last time, I think it'd be easier if we had something where we could kind of compile it all in one place. So if you could just share that in writing, that would be fantastic.
This is Stuart again. Should we just email Aaron, I guess?
Mm-hmm. Yeah, emailing Aaron, if that's okay with you, Aaron.
Yes, and Emily, if you don't mind to send me an email exactly what it is that you want from each MCO, I can send that to them and make sure they cover exactly everything that you want covered in that request.
Okay, sure, I can do that. Let me make a note to myself.
Hey,
Emily,
Emily, this is.
Oh.
Oh, I'm sorry.
Go ahead, Ashley.
Hi, it's Ashley with United. Emily, just confirming that you did receive my email with UHC's out of network numbers.
I did. Yes.
Okay.
Thanks, Ashley. I remember
Thanks.
that one.
Emily, this is Michelle with Aetna. You just wanted that in reporting format and not presentation format, is that
Oh,
correct?
yeah. It does not need to be a presentation.
Okay,
No.
thank you very much.
I mean, appreciate when people put in the extra work, but it's not necessary for this. So, yes, I will email Aaron though. And then if anybody has anything else you want to add, that's fine. But just so that we can kind of have something that is easy for us to compare side by side. And
Ashley, this is Erin. Did you copy me on that email to Emily? And if not, do you mind to send that to me so I can compile it all together so I have all the MCO's responses?
Yeah, let me double check, and then I'll forward it to you, Erin.
Thank you. Appreciate that.
No problem.
all right. The next item we have here is the request that we made at the last meeting for data reports. I think, Angie, you had shared that there were a few different reports that DMS receives: geomapping, timely access, quarterly audits. And I think that you were planning on sharing those with us, or there was some way that you were going to be able to get us that information.
There is someone who in the department that has oversight of all the data reports. Would you actually want to see the results of the reports? Or just what they were?
Oh, no, the results, I guess, is what we're looking for.
Yeah, that's the challenge when you have 6 and trying to compare them all. It may be something that we may need to ask of the MCOs to provide. Because I think it's a monthly report of all of these requests. Well, there's quarterly audits, and then there's and exceptions, if they don't have the exceptions report is if they don't have coverage for certain area for whatever reason, they ask for exceptions. I know you've been wanting this, and I apologize not having this ready for you, but it is, like I said, it is a challenge when you have 6 different MCOs and putting them all in one when there are a lot of different variables in those reports.
Well, if you want to come up with something that you think would be easy to pull together and share with us, we could do it that way.
Sure. I'll just look a little at this a little bit closer, see what we need to do. Okay, I'll try to have something for you the next time. I apologize.
All right, thank you. And then our last item here is the dental vision and hearing services regulations. And of course, those are now the emergency regulations comment period is over. And I think we're in the ordinary regulation comment period. But any updates there that you all can share with us?
Sure. So the ordinary regulation comment period is going to go on through the end of this month. Most of the comments that we have already received just asked to be applied to the ordinary regulation as well. So we're compiling, summarizing, and preparing responses to quite a few comments. I don't know that I have the final number of comments we received. We received 1 negative comment and then a whole lot of positive comments, and just a lot of excellent research and a lot of really well thought out arguments and really thoughts that we hadn't had before. So thank you all for your part in that and your research and work on that. It's been very interesting to read and just really helpful as we keep moving forward with it. We expect the regs, excuse me, to not be on this month's ARS committee. We do expect them to be on next July. I believe it's the 13th. And then we will probably be deferred, and then we'll probably be on either the September, I guess, September for the ordinary regs. So that's kind of the schedule we're looking at right now, and just compiling everything and getting ready for next steps and moving forward.
Okay, that sounds good. And you'll have by that July 13th reg review committee, that's the legislative administrative reg review committee for people listening. You'll have a report of the public comments that you can share then, or how do those comments get shared?
We will just share them. I guess since we have already passed the end of the month, those are official comments we've received, so we can give you the entire comment if you want to see all of the comments kind of compiled, and then just the statement of consideration that we file will summarize those comments, and then that's what we'll respond to under KRS 13A.
Okay, that sounds really good. So for committee members, if you haven't already, I would just encourage you to submit comments on the ordinary regs, which are identical to the emergency regulations, right, Jonathan?
Yes.
So you didn't miss that opportunity, really, if you didn't submit comments on the emergency regulations. But for just so many reasons, these are really, really critical services for Medicaid members to have access to. And I think we need to make sure that the legislators know that there's a lot of support for these. So KVH has put together a comment collector, and if I haven't shared that with you all, I'll share that in the chat in case it's a little bit more convenient to share your comments that way. But of course, you can send them directly to DMS as well. And the only other thing I wanted to ask about that, I just really wanted to clarify, I think, for people listening, for our committee members, that these regulations will stay in place, even if there is a deficiency found. For anyone who paid attention to or was watching the June Reg Review Committee, they did actually not technically review the emergency regs, but they were on the agenda for discussion, and they did take a vote and found them deficient, but they are still in place. And I was just on a call earlier today with community health workers, and almost no one thought that these services were still in place, including CHWs who work for providers. So that was really alarming to me. Not entirely surprising. I knew that there was some confusion, and that some people had the perception that a deficient reg meant didn't necessarily mean that the service was no longer covered. But I was surprised by just how many people were either unaware of the regs at all, or thought that they were no longer in place.
Yes.
So if there can be some clarification maybe sent out to providers too, I think that would be really helpful, because I would hate for people not to get these services because they either weren't aware of them or assumed that they were no longer covered.
That's right. We anticipate that they will be in effect, going forward, and it will be a question for the next legislature whether they're going to be able to stop them.
Well, thank you for that clarification. And yeah, just any information that our TAC members can be sharing in their communities with providers that and work with, and of course Medicaid members, would be really helpful. So I think it will take all of us making sure people are aware. And any questions about that from committee members or TAC members? We can move on then to new business. So one thing that I wanted to bring to DMS's attention, and I think at least some DMS staff are aware of this, but there's on Connect Now a get contacted sort of a button on Connect, but it refers a consumer, somebody who's looking on Connect to either renew or to apply for coverage, refers them to insurance agents. And that button was initially on every page, it seemed, even like the Snap page. I've noticed that that's been removed. So thank you for whoever removed it from there. And it's no longer on the Medicaid page either. So that's already an improvement. But we have gotten reports of consumers, reaching out, pressing the button, not really understanding that it's only technically for people who are wanting to enroll in a qualified health plan, because that's really what agents focus on. And so we've gotten a lot of reports of people who clicked that button, wanted assistance with a Medicaid application or a SNAP application, kind of got the runaround and essentially had to go back to DCBS and it took more time than it saved them and didn't really provide them the assistance that they were looking for. So mostly just want to put that on your radar. Hopefully, if you have any, plans on, improving this, it would be great to know about that. And Miranda, as a connector, you may have more to add, but that's been something that has been a little concerning, especially with Medicaid renewals happening now.
Emily, I wanted to apologize. My Zoom is being very finicky and it stopped sharing my screen. And so I'm trying to pull the agenda back up. So I apologize if it's doing something wonky on your all's end.
Well, thank you. I understand these things happen with Zoom, and I have the agenda pulled up for myself. So hopefully other people have it as well. Is anybody on from DMS who can talk about how we're going to have that button may be refined, or how we're going to better target just to qualified health plan folks?
Is there anybody from eligibility on? We can take that back and get that to somebody from eligibility to respond to that.
We can add it to the next agenda, Justin. I'll make a note to myself. And by then, it may be that some of these issues are resolved, hopefully so. But just wanted to make sure that everyone is aware of that. Miranda, have you had any issues or concerns with that?
I just have the same concerns that you raised.
Yeah.
You have to go in 5 minutes.
Thank you, Arthur. Why don't we then jump down to recommendations so that you can help vote on those, and then we can talk about the orientation packet. We are close to the end of the agenda, so that's good. So the first recommendation that I was thinking of making is related to those dental, vision, and hearing regs, and just recommending that DMS provide clarification to providers about the status of those services.
You made
Make it for clarification to providers and connectors.
And connectors, yes. Yes, thank you. That's a very good suggestion. And should we, or communication to providers, and okay. So that DMS provide communication to providers and connectors about the status of the Medicaid, dental, vision, and hearing services. If that sounds like, oh, are you going to make a a motion?
Yeah.
Okay, thank you, Arthur. Can I get a second?
Second.
Thank you, Miranda. All in favor, say aye.
Aye.
Aye. Any opposed? Okay, that motion carries. I was,
And Emily, this is Justin Derringer again. I'm sorry to interrupt you. Would you mind shooting, I guess, just Aaron an email about that, just specifying that button issue and so that we can get you an exact answer?
the button issue, yes. And I do think that this has probably been brought up with KHB. I just wasn't sure how involved DMS is. And just wanted to make sure that that was on everyone's radar. But I will email Aaron with a little more information. So another, I don't know if we need to make this as a recommendation related to the value added benefits. I think we can see what Angie is able to come back with. Are there any other recommendations that TAC members wanted to put forward? Okay. Well, thank you, Arthur, for joining us. And if you need to hop for your next meeting, we understand. We'll go back up to the new business MAC and TAC orientation packet. Aaron, I know you have been working on this. Is there more feedback that you'd like from us?
Kelly has actually been working on that. That's something she's done in a previous role. I believe she's kicked that up to Veronica to look over. With that being a MAC recommendation, I think those are due July 10th. So you should see it on or before then. She's just running it past upper management, and then once it's ready, we'll send it out. And then if you guys have feedback, I'm sure she's happy to look into that. But Kelly has been working on that very diligently.
Okay, great. Well, thank you to Kelly. You're on.
That is almost finished. There are several documents in the packet so far. What's taken me some time is the acronyms list. As I'm sure you know, Medicaid has lots of acronyms, and all of the different departments within Medicaid, with all the different divisions within the Department of Medicaid, kind of has their own set. So we've been working on putting those all together and paring them down so it's not so overwhelming to the members. That's kind of what's taken some time, but I have sent it on up the chain to the commissioners, staff, and just waiting on kind of that acronyms list and then getting the packet approved, and then I should have something for you next time we meet.
Okay, thank you. Thanks for all your work on that. We'll look forward to seeing it. I do have an acronym list. It may not be better than yours or more comprehensive, but I'm happy to share it with you if it would be helpful, just to, so you don't have to recreate anything.
Yeah, I've gotten several, so if you want to just send it to me, I can kind of see how it compares to what I already have.
Just kind of cross-reference them all, yeah.
Yeah, that'd be great.
I can do
Thank
that.
you.
Okay. I don't think that we have anything that we need to discuss, under the general discussion item, but let me know if anybody had anything else that they wanted to bring up. Okay, I'm seeing a no from Miranda. Anybody else? All right. And then for the next MAC meeting, I'll be there to provide the report for the consumer TAC. And we have 3 remaining meetings this year. I just can't believe that we're halfway through the year. There's just something about that I just can't understand how this year is halfway over. And those meetings are August 15th, October 17th, and December 5th. So at the August 15th meeting, we will add Arthur's agenda item. We'll do some of the follow-up that we discussed today. And hopefully we'll have a report on those quality metrics. And we have, of course, a couple other MAC meetings left as well. Those are the 4th Thursdays at 10 a.m. And those are the ones that I attend, but of course they're public and open to everyone. So any of our consumer TAC members are welcome to join. I don't have anything else for the agenda, so just give it one more. Anybody? All right. So thank you all again. And I always ask you this, do we make a motion to adjourn? by acclamation. I think we can adjourn by acclamation. So that's what we'll do. Thanks again, everyone, for attending today. We'll see you next time.
Bye-bye.
Thank you all. Everybody have a good day.
You too.